Welcome to episode 205. Brian Sims is the Chief Medical Officer Director with NASBID, and he's going to be our host for today. We're excited to have Michigan in the major focus with Krista Hauserman and their approach to crisis system design overall. So that's going to be our feature presentation. Don't hesitate to jump to talk.crisisnow.com. It's your go-to website for joining the community, learning about the week-to-week content, signing up for our weekly newsletter, as well as the YouTube from last week. Heidi Warrington bringing us nursing in crisis care. Really terrific focus that we've not had enough of. But you can see all of the past presentations, trivias, quotes, and more at talk.crisisnow.com. There have been over 500 of you actively participate in the show as a speaker. So Brian, when you jump back in, just take the reins. I'm not saying you jump in yet. But we've had over 500 of you in over 200 episodes as part of the program. You've spoken on the Crisis Jam, and we want to know your ideas. Let us know a debate you'd like to be engaged in or a topic you'd like to hear, and we'll work with Samson, NASBID, and the team to get that on the agenda. These are the actual names of those 500 people who've been part of the program, and of course, Brian Sims, the host today. You see his name highlighted there. In coming weeks, we're going to ramp up the debates. We've been talking about this, but want to give you a quick look at this. We had 3 debates at the Crisis Now 3 Summit in Amsterdam, and we've had 3 over the last year and a half in the Crisis Jam itself, but we're going to start a much stronger cadence with with every month. We're going to be bringing you a topic. And so Megan, you want to step in?
I'm happy to.
Megan, tell us about the debates that we've got coming up.
All right. So we've the debate piece is just such a great way to talk about issues. The one February 5th, we're trying to actually have one once a month, will be Dr. Margie Balfour as well as Travis Atkinson to talk about crisis facilities should take both voluntary and involuntary referrals. Dr. Balfour will take the affirmative, and Travis Atkinson will take the different perspective on that. And then coming February 26th, we'll have Hannah Wasilowski as well as Tom Betlak to talk about how all states should enact legislation that includes a 988 fee, similar to how we pay for 911. Hannah will take the affirmative on that, and Tom will take a perspective, just alternatives. He's not against the fee, but he'll just take that alternative perspective. And then coming April 2nd, we'll talk about mobile crisis should always be dispatched by the local 988. And Justin Chase and Preston Looper will take those different perspectives. And really excited that April 23rd, we'll talk about the IMD should apply to beds in an emergency behavioral crisis receiving facility. And Jennifer Mathis, who is currently with DOJ, but moving to the Bazelon Center, will take the affirmative, and Dr. Brian Hepburn, our own NASBID CEO, Chief Executive, will take the negative on that. Wonderful. And we are also emphasizing the lived experience library. We have so many resources that we've been sharing. You can see here just some great pieces. And I understand Brian Sims is back. And so, Brian, did you want to talk about what resources and books and publications have been shared so far.
Well, first of all, I want to thank you for covering.
Absolutely.
Unfortunately, my Wi-Fi has decided that I'm not going to be hosting today. So I'm going to try to do my best, and hopefully it will not go out of game. Yes, I do want to just mention in there with regards to these upcoming lived experience libraries, there are things that we want to look at in the upcoming year. You'll see a lot of them that will be featured in February, and you'll see more of these as we proceed through this year. I do want to quickly go into the next area, though, because there's a couple of articles I want to highlight before we get to our hot seat. And as first one is from Time, and it's the mental health toll of California wildfires. This is something that's kind of a given per se in terms of understanding it, but it's also a continuum. We're looking at the fact that this is adding to recent disasters that we've had across the country. So it raises awareness of the need for mental health services and crisis intervention services. And next slide, please. I also want to raise up this particular portion called AgriStress. It's an AgriStress helpline, and it was actually being used right now by 11 states. And they're providing extra training to their staff. So that in crisis intervention, it is specifically designed to work with the needs of agricultural workers. And let's go now to the next slide. And we're at our crisis trivia hot seat. And I did want at this time to, as always, open it up. If anyone would like to volunteer to be a portion of it, please jump on board. We'll be happy to accommodate you. But if not, we will do it as an audience participation. Okay, so then moving on, in this crisis trivia hot seat, as we see here, in A Paradise Built in Hell, which is a book written by Rebecca Solnit, she challenges the common belief that disasters lead to widespread panic and social breakdown. Instead, she argues that disasters often bring out extraordinary acts of community and mutual aid. So for all of us, the trivia question is, which historical data does Solnit not explore in depth in her book? Would it be A, the San Francisco earthquakes of 1906, Hurricane Katrina in 2005, the London Blitz from 1940 to 41, or the Indian Ocean tsunami in 2004? So we'll give it a moment for everyone to kind of connect on that and see where we are. I'm kind of curious on this because I had no earthly clue. And it says it looks like here the London Blitz is standing out for the audience. So we want to go ahead then. We have those results. Otherwise, there we go. So it looks like roughly half of you are saying the London Blitz, with some saying, I guess at a higher percentage beyond that would be the Indian Ocean tsunami, followed by San Francisco earthquake, and then Hurricane Katrina as the last. Well, then let's move to the answer, audience. The answer is actually the Indian Ocean tsunami in 2004. Because Londoners supported one another through acts of bravery. They shared sacrifice and collective resolve despite sustained bombings. And the Solnit highlights the local impact of clear community response characterized by resilience and mutual aid. This is something that we're all seeing actually in practice by some of the disasters that have come up recently, these heroic acts of community connection, collaboration, and assistance of one another. So next one, and thank you all for participating in the crisis hot seat. This last article, just wanted to mention about disaster response with the central role of crisis centers. And this is an issue that's coming up. April Naturel will be speaking about this sometime in March. So it's just a heads up that LifeNet has had relationships with governments at all levels. So we're going to be talking more about that in the near future. All righty, well, let's go to now our feature presentation. And we are honored today to have with us Krista Hauserman, and she is the Crisis Services and Stabilization Section Manager with the Michigan Department of Health and Human Services. So we welcome you, and please take it from here.
Thank you. Thanks for having me today. I'm pleased to be able to share some of Michigan's crisis infrastructure work with you today. It almost seems a little premature as we have so much work left to do. We definitely are still in the building phase. I agreed to present today because I've learned so much from my counterparts in other states. In fact, if something in my presentation seems familiar to you, it probably is. Next slide. Here's a diagram of our Michigan model. This model is based on SAMHSA's national standards and the crisis system that we see developing locally in Michigan. It's our North Star where we're headed. Please note the under construction sign in the upper left corner. Building a crisis system, as you know, is a long-term project. We put under construction on there because we know that we'll have change and improvement over time based on experience and learning. Under construction is also on there because we are phasing in the requirements with our providers and communities so that the changes that we're making are realistic and it's not overwhelming for them. This means that our regional systems are at various stages of development right now. It does seem like we're working on everything at once, and I think that's really because we are working on everything at once in Michigan, like many other places in the country. This crisis system that we're building is for all Michiganders with all diagnoses and all payer types. Our primary crisis providers in Michigan are Community Mental Health Service Programs, or CMHSPs. The Michigan Mental Health Code requires CMHSPs to provide crisis services. They do this either directly or contractually. We're also a state demonstration CCBHC state. Most of our CCBHCs are CMHSPs, and the ones that aren't are required to partner with the local CMHSP on crisis services. You can see in the model that 988 is an easy statewide access point. We have one primary 988 center, which answers about 85% of the calls and will answer all of the chats and texts. The Michigan legislature legislated one call center, Michigan Crisis and Access Line, and this happened pre-988. This model that the legislature set up allows us to build a strong centralized 988 line. Having one primary line also saves us some funding and workforce. We estimate that the difference between having a 6-line model and a 1-line model is about a 30% savings, both in funding and workforce. I want to point out, though, that crisis calls can come directly to 988. And then if somebody needs more than the phone, text, or chat support, they can receive that and they'll get immediately transferred to a local crisis hub, or the calls can go directly to that local crisis hub. Crisis hubs are the term we use for the access point to our local crisis system. Again, as I mentioned, where people can access crisis care when a call, text, or chat is not enough. We made a decision to go with the local crisis hub model because it was developing organically across our state. It actually predates 988. The statewide 988, having that statewide centralized access point, along with the local crisis hub partnership, brings Michigan a blend of central access and local customization. CMHSPs have long been required to have 24/7 crisis lines. Many of them have well-established and well-known numbers. Some of the numbers have been around 30, 40 years. It's a long-time system. These are the lines which will be transitioning into the crisis hubs. Local crisis hubs are familiar with all their services in the area and what crisis service is available at any moment in time. They're also familiar with the region, the people they serve, and little things like how to correctly pronounce street names during a mobile crisis dispatch. The local crisis hubs will receive calls from law enforcement, local emergency departments, people in need, and 988, in addition to others can call them as well. But that's where the calls will come in when law enforcement might be on the scene and they need extra support. They can call directly to the local crisis hub. They don't have to go through 988, although they can. Same thing with emergency departments and some of our other partners. Those crisis hubs will be staffed, and they are staffed to help the caller identify the best crisis care option for the caller in that moment. So to be able to walk through that process with the person, figure out what their preferences are, what their needs are, and they will have the skills, training, and degree to be able to do that. Our crisis hubs will also dispatch mobile crisis. The crisis hubs are partnering with local 911 and law enforcement around mobile crisis implementation, 911 diversion, various initiatives like that. The services in the dark blue on this model are the emergency services. They require no pre-authorization. Anyone can access them at any time. The services in the light blue box are considered our post-crisis stabilization services. We put this designation on the model because of that pre-authorization component. And this was also, these terms come from CMS, that emergency service designation versus the post-crisis stabilization designation. We have categorized our services, we bucketed them according to service location to try and make it simple for the public and stakeholders to understand. So you see the little, for the some safe place, so for the someone to respond, you can see the little ambulance on there. The someone to respond services is defined as the care coming to the person. So the person can remain where they're at and the care provider comes to them. This could include the person staying in their home and having a telehealth response. The others, the safe place to be, we talk more about that in Michigan, is the person going to a safe place to receive care. The person can walk directly in to receive the care, or they could go through the crisis hub. I do want to point out that we do recognize and know that mobile crisis is a best practice for youth and families, and that it's really important to build out that service. So you can see we have a little star on there, and that's flagged specifically. So our stakeholders know that that is the priority crisis service for youth and families. Michigan has a three-pronged internal work group at MDHHS, and we work together all the time. And we work together. It's one of the things that I think we're really strong at, is ensuring there's alignment between different parts of the department. And so we have, we meet regularly with our kids services group, adults, and then our CCBHCs. And we're building these model requirements into a Medicaid policy and a crisis program certification. Each of our CMHs will be required to be certified, and the certification process will describe, through the certification process, local regions will describe where they're at and building out their crisis service array and plans to grow into this model. We have a phased approach for this model as well. We're already starting to talk about a phase 2, where the requirements will be just a little bit more stringent than phase 1. Again, we don't want to overwhelm our providers, but we want to move ahead because we know that the system's really important for all Michiganders. I'm going to switch to the next slide, please. Thank you. Michigan is really fortunate to have strong foundational components to build on this. I already mentioned the mental health code, which along with its administrative rules have set up MyCal. They have requirements that the components in the various crisis systems partner together. And again, they obligate CMHs to be crisis providers. That is a really big component for us, in that we have mandated crisis providers. So in some ways that makes that whole contracting partnership process much easier because we know who we're going to be partnering with. In addition to the mental health code and administrative rules, we also have other regulations which are helpful, which is a lawsuit settlement for kids that's in process, CCBHC crisis requirements, and the Blue Cross Blue Shield crisis benefit, all of which are pushing our system forward. MDHHS is very strong in involvement with internal and external stakeholders. We have work groups for everything. I already mentioned our internal work group, which meets all the time. And then as we have other work groups as well, like an advisory work group that involved 10 providers and people with lived experience to help us develop the adult CSU certification process. I think these strong partnerships have been really helpful when it comes to implementation because they really have a voice in all of this. Next slide. I want to touch very quickly on the platform that we use for our 988 line, and this also is used for other processes like regulatory processes in MDHHS. This is our 988 vendor says this is the brains for 988. And not only does it guide the call flow and have a crisis risk assessment built in, but the 988 staff can access resources in here. It's integrated with 211. And our CMHSP and CCBHCs are mandated to input crisis and access information into this platform. And then those same providers can receive referrals in real time through this portal. Next slide. Workforce. Michigan has workforce issues just like any other state. We're taking a two-pronged approach to addressing this. One is we're maximizing our workforce through specialty crisis trainings. We're partnering with Wayne State to roll out a crisis training specifically for degreed staff, which will allow people with a broader ranges of degrees to provide crisis services. We also have peer crisis training for adult peers. We're developing peer crisis training for peers working with youth and parents. And we have a standardized crisis training for law enforcement academy recruits, our behavioral health emergency partnership. That has a multidisciplinary module, which we are going to start working to pull mental health providers and first responders together so they can get a little cross training. The other way that we're working on workforce is we are maximizing, when we develop program rules, we're maximizing we're building in flexibility for rural areas to maximize the use of staff so they can work at the top of their licensure and so that staff can be shared across programs. So for example, mobile crisis requires master's level supervisor. We're encouraging rural programs to share a master's level staff as capacity allows, if that works for them. Next slide. I want to finish spending a couple minutes talking about diversified funding. This is a challenge. I know it's a challenge across the country, but in Michigan, we are committed to developing a diversified, sustainable funding system for all payer types. We are really fortunate to have a strong private payer partner with Blue Cross Blue Shield. Our certification rules that we're developing require providers to accept all payer types, including private insurance, so they know that they need to be able to bill private insurance. We want to develop bundled rates for our crisis stabilization units and mobile crisis, while ensuring that we're still funding services for 24/7 availability. Right now, we're focusing initially on CSUs. And a couple things I want to mention, Michigan, as I mentioned before, is unique in that we have a defined set of crisis providers through our CMHSPs. This allows us to have a little bit more open discussion around rate setting and needs than maybe can occur in some other states. We did explore rates in other states and tried to look at some of those rates in other states and figured out that sometimes the rate that's posted by the state is not necessarily the rate that the provider gets. And so that was a learning for us. We're trying to be really careful when we're developing these rates and we're in the development of the bundled rate in that that we have a similar process as private payers. We meet regularly and have met regularly with Dr. Beecroft from Blue Cross Blue Shield. We know that if providers had multiple sets of program requirements and their billing practices, if the bundled rate for CSU incorporated different services for Blue Cross than from MDHHS, it would be too administratively burdensome. So we've worked closely with Blue Cross to try and align those things and continue to have those conversations. And so this is one of the priority areas that we continue to work on. And at this point, I'm going to stop my presentation and leave time for my colleagues to share as well.
Wow, Krista, thank you so much for that presentation. Very comprehensive. Absolutely love it. There was one question before we go to the roundtable that I wanted to share with you. Melissa Vega places in there, first of all, thanking you for the presentation. But she says, do you ever find that mobile crisis has a longer wait time than usual? And if so, does that change the way that your local crisis hub responds?
So I will say that we're still really rolling out mobile crisis, and I do think there's longer wait times because we're still developing that service. I think our crisis hubs are trying to, as they're rolling this out, they're trying to think through and be creative. Like some of them talk about having somebody available to talk to the person on the phone while somebody's being discharged. Or not discharged, while they're waiting for that mobile crisis team to come. I will also tell you one of the reasons why we ended up with the crisis hub model is if somebody knows they need mobile crisis, or if law enforcement knows somebody needs mobile crisis, we think it's just faster for them to get right to the mobile crisis dispatch and not necessarily go through 988. Because when the crisis hub gets that call, they're going to know that a crisis service is needed, because that's why somebody's calling to get that service. So we'll see. We hope in Michigan that helps streamline that process a bit.
Well, thank you. Thank you so much. We're going to move now to the roundtable discussion. And first on the roundtable is Dr. William Beecroft, who's the Medical Director of Behavioral Health, Blue Cross Blue Shield of Michigan. And Dr. Beecroft, thank you so much for joining us, and your comments, please. And we'll have to take you off of mute, sir.
It's Wednesday. That's my excuse. Thank you very much for the time. I appreciate the opportunity to do this. It's been a journey with DHHS of Michigan, but it's also been something that is near and dear to my heart. As a consultation liaison psychiatrist, I took care of a lot of people in the med-surg observation unit with psychiatric issues. And the crisis stabilization unit is essentially identical to what you would do in a med-surg crisis observation unit. So with that, you can, as SAMHSA has pointed out, our lived experiences for the last 5 years in really piloting this with providers in the Detroit area has been that about 60% of people don't need to go to a hospital, which is substantially an improvement in care, because you can repurpose the monies used from that hospitalization to other alternative levels of care, outpatient, partial hospital, crisis residential, whatever they need. The other piece of that is that as the biggest blues payer, well, the biggest insurer in Michigan, except for DHHS, we have about 55% of the population under our insurance contracts. So that's about 5.5 to 6 million people. And we also have people outside of Michigan as well. So really getting behind this issue of using crisis services to be able to get people services quickly, be able to have rapid access and thorough evaluations, initiating treatment in the crisis stabilization units that day. I found in treating people in the hospital that many of my patients, probably a good 50% of them, by the time day 2 or 3 rolled around, they really didn't need to be in the hospital anymore, but I couldn't discharge them because of all the administrative stuff that has to happen to be able to get people out the door, which took another 3 or 4 days. The stigma of inpatient hospital is really significant as well. Whereas if you can go to an outpatient service, say it's on a strip mall where you have the crisis stab unit or the mobile crisis team, nobody knows you're going there for a behavioral health condition. And it's behavioral health. It's substance use disorder and mental health together. So this has been a really great journey. I have a slide I can share if I can share one. Is that something I can do that can show you our progress? If not, I can kind of verbally tell you. You know if I can share a slide? I can give it a try. No, it's not going to let me. Basically, we have in the last 2.5 years have under contract CMHs, vendors of CMHs, and providers that are working with us for roughly 80% of our population in Michigan. It incorporates essentially everything south of Mount Pleasant. If you know, that's kind of in the middle of the state, so right about here. And in our rural areas and the very rural areas of mid-Michigan, northeastern Michigan, and the Upper Peninsula, we're still working on developing contractual relationships, but many of those providers already work with us. So the fact that this is a service that is available to any individual in those communities is really helpful. And if they happen to be a Blue Cross patient, we will reimburse for that. We have bundled our rates. So we followed that lead from the state of Michigan to try to make it easy. The one thing I would ask and to call out here is that the services that are usually defined for mobile crisis and crisis stabilization are not currently benefits for Medicare. And we've had to add that into our Medicare bid to be able to get our Medicare members, Medicare Advantage members, service with this as well. But that has not been able to be done in Northeast and the Upper Peninsula because we don't have enough providers in that area to fit Medicare's requirement. If that was something that was available as a benefit for Medicare patients, that would be extremely helpful. So thank you very much for the time. If there's any questions, I'll defer to, I think Dr. Pinos is available here as well.
Yes, indeed. And thank you, Dr. Beecroft, for those comments. And we will move over now to Dr. Deb Pinos. And Dr. Pinos, I have to say, I would say senior medical and forensic advisor with NASHBID, because if I add the other things, we'd be at 1255 with all of the other titles that you have. So we'll stop there. And your comments, please.
Oh, that's funny. Thanks for the great introduction. And I got to say, big shout out to Krista, who has done a phenomenal job with her vision and our leadership at the Department of Health and Human Services. So people who know me, I do have several hats. One of them I wear is through the University of Michigan. I work as a contractor with the Department of Health and Human Services in Michigan as the state medical director advisor on these kinds of issues. And then you'll hear from me later in my NASHBID hat. So I've been working with Krista and Dr. Beecroft for a while. And I just want to point out a few other things that I think are useful for people around the country to think about and hear about. The first of all is that a lot of this has started with getting legislators on board and getting statutory reform in Michigan. We had a group of partners, community providers, and others who really wanted to build out crisis services. And legislation was passed a while ago around the MICAL, the Michigan Crisis and Access Line, even before 988 was a real thing. So that set the stage. The second piece of legislation is an addition to our mental health code, which allows for crisis and envisions the crisis stabilization units, which operate under statute and then gives the authority to the Department of Health and Human Services to certify them, which is why we're really building out certification. And we've looked around the country at a lot of other, probably every other state, and looked at rules that exist around the country to help create our rules and what would work for Michigan. So thinking about your statutory and regulatory environment is really going to be critical. We're working with, I see Alyssa Newmeyer is on the call. She's heading up our crisis stabilization unit services. There's a whole team of people. Heidi Warrington is our nurse consultant. So it really takes a village to think about this. And then our partnership meetings. We don't always see things eye to eye. We had a really hot button conversation today on an issue around thinking about how to ensure the proper medical clearance for people coming into crisis stabilization units. But we're trying really hard to listen and then still develop policies that we think are going to provide practices that we feel like we'll be able to certify. The second thing I want to point out is that we have in Michigan a really unique partnership. I was super excited in my role as the psychiatrist medical director to find out that through Western Michigan University, there was a contract that our state medical director for emergency medical services, an emergency medicine physician, work. So we work in parallel. Dr. Bill Fales and I have been working in parallel around first responder training. That's how we got to this multidisciplinary training with police and law enforcement and EMS. But we have a fantastic partnership with our EMS team. And that's another group to think about reaching out to as you're building things. We're really trying to build continuity across all these crisis services. So everything speaks to, they all kind of speak the same language. And then through that EMS partnership, also trying to have it speak the same language with EMS and emergency rooms. And then finally, I would just add that we are also looking at our kids services and thinking about how to build a system that's really youth focused rather than just building a system of adults services that, tack on the idea of serving youth, and really thinking about how to build out youth crisis stabilization, youth mobile crisis, really thinking about the youth and the families that are partnering. So we have a lot of interesting components, and watching the dots connect is really part of the fun of really thinking about systems networking. So anyone sitting at the table at a local level, you want your local systems to be networked. And then at the state level, you got to have your state systems networked so that the left hand and the right hand are not pulling against each other, but really working in partnership synergistically. So I think with that, I'll stop. I don't know if there's any other questions, but very excited about all that's happening in Michigan and having Krista as our lead.
Oh, wow. Well, Dr. Pinos, I do want to thank you, especially for the last portion you talked about the youth and young adult in terms of focus. That's often a kind of overlooked piece. So I'm really happy to see that Michigan is really focusing in that direction. But also with all of the things that all of you provided, Krista, absolutely outstanding presentation, just very comprehensive. And then with the comments from Dr. Beecroft and from Dr. Pinos, has just really opened the understanding of where Michigan is. And hopefully, we can start to look at these services as kind of a standard for what we do across the country. So thanks to each and every one of you for this presentation. And at this point, we will move now to our SAMHSA update. And we are privileged to have Dr. Richard McKeon, who will provide our SAMHSA update for today. Dr. McKeon?
Thank you so much, Brian. Very much appreciated, and was really great to hear about all of the outstanding work going on in the state of Michigan. I will try to be brief, but here are a number of SAMHSA updates. One is that 14 states and Washington, D.C. were just awarded CCBHC Medicaid demonstration planning grants. So as you know, there's close collaboration between SAMHSA, and particularly the Center for Mental Health Services, and CMS, regarding these Medicaid demonstration grants. So that's one thing that was just recently announced. Also, just within the last 7 to 10 days, several SAMHSA documents were released, and I believe it's going to be a feature next week, if I understand correctly. The National Guidelines for Behavioral Crisis Care, the accompanying definitions document, the Mobile Crisis Toolkit. So ample, important reading for everybody, available on the SAMHSA website. And then just before that, and I see the chat note from David that Belina Shaw from the Center for Mental Health Services will be doing that presentation next week. Also, this about a month ago, a little bit further back, SAMHSA released a really important document on when to contact 988 versus 911. This is intended to be a guide for providers on what to tell their patients or clients about the appropriate use of 988 versus 911. I think it was very important that there was an official SAMHSA document that put this out. And in that same vein, there's work going on currently for a release date, hopefully in late spring, for a 988 and 911 risk and liability toolkit to help provide some guidance and reassurance, perhaps, around those types of concerns. So, Brian, I will stop there and back to you.
I thank you so much, Dr. McKeon. I know you have to go elsewhere, but safe travels and wherever you're headed. But thank you as always, and thanks SAMHSA for their wonderful updates and keeping us in the loop with all of the things that are occurring. We're now going to move to the NASHBID update, and we'll bring back Dr. Deb Finals, our Senior Medical and Forensic Advisor with NASHBID. Dr. Finals?
Yep. Hi, all. Okay, switching gears here for NASHBID. I just want to talk a little bit about some of the work that we've been doing, and one of the papers that just got put up on the website on extreme risk protection orders. You can go to the next slide. As people have heard, potentially, most of you have heard, and if not, you should know. That's the slide, thanks. We work on Technical Assistance Coalition papers on behalf of SAMHSA at NASHBID, and we have some fantastic collaborators that help write these papers, and Jeff Swanson, one of the leading researchers around the country on extreme risk protection orders, and several colleagues and some of us at NASHBID helped contribute to this paper that was produced to really help states and practitioners think about this. This is not something we talk about often on the crisis jam, but it's important to know if somebody comes in to a crisis, or if a crisis worker or somebody is aware that somebody might be a risk related to a firearm, whether that's suicide risk or violence risk, which we know suicide risk is really the number one risk related to firearms, that there's a mechanism in many states to help have that firearm removed with the possibility of that person having their gun rights returned to them. And these are called extreme risk protection orders. They don't require a finding of mental illness. And that's one of the things that's, I think, good about these. It's just any time you're worried about somebody in the states that have these laws, there is the ability to remove the firearm. And so take action first and then sort out what needs to happen around that type of risk. So these laws are not available in every state, but they are in at least half the states at this point. They're a little bit different in each state. In all states, family members can petition, and sometimes other third parties. Sometimes clinicians can petition to have that firearm removed. In the states where clinicians cannot petition, they have to work with family members, unless there's other laws that are there, like duty to protect, that allow confidentiality to be breached. But this paper really goes through the mechanics of what is an extreme risk protection order, how does it work, what are some of the risks and challenges related to these laws for practitioners, for people who want to make sure their firearm rights are preserved. So it's really written just as a fact document, looking at some of the data that we know about these laws and how they've worked across the country. So if you have them, I know Michigan, for example, is one of the states that recently passed legislation for an extreme risk protection order. And many of us are talking about, well, how does this work in clinical settings? How would it work in a crisis stabilization unit? How would it work in an outpatient clinic? How do we think about this? And so we've been doing a lot of trainings in Michigan, and this is a tremendous resource, I think, for the country to be able to see. Now, stay tuned, because there are other papers. There's one also that's up now on measurement-based care in school, and we're hoping to see the other ones come out soon. But these are all about next steps, thinking beyond just the crisis, but really thinking about that infrastructure to support and prevent crises from occurring, and really thinking about infrastructure development beyond the crisis. So that's the report from NASHBID today. Thanks, everyone. This is available on the NASHBID website. I'm sure Megan or someone will be able to put the link to the paper so that people can find it themselves. Thanks.
And thank you, Dr. Finals. I do want to emphasize one point that you made towards the end, and that was looking at the provision of these papers and so forth, to take a look at prevention. I love the use of the word prevention, because that really is the spark of what we should be doing, is trying to see if we can stop it from occurring rather than waiting for it to occur and finding issues that we have to do to deal with it. So thank you again for that wonderful update. We're now going to move to our Crisis Jam feature, and we have with us our Joanna Rosen. And Joanna, for our federal updates, I know you're a very popular person right now, so please take it from there.
Hardly I am. Everyone, happy New Year. I don't think we've had a federal update this year yet. As we all know, a new president, or I guess a returning president, was inaugurated on Monday. The president has nominated Robert F. Kennedy Jr. as the Secretary of Health and Human Services. We're going to be tracking his confirmation hearings as they occur. For now, the interim acting secretary is Dorothy Fink. And I can pop some links with a little more information below. I saw some comments in the chat about how changes at the federal level in terms of budget and services and federal employees, how that might impact us and crisis care and healthcare in general. We are still monitoring whisperings, about who's going to be heading SAMHSA, what this means for 988, for funding too, specifically for the budget. The federal government is still operating on a continuing resolution, funding the government through March of this year. We are hoping to see progress on a final FY25 budget soon, now that Congress has started the 119th session. We're especially expecting many congressional offices and lawmakers to sort of already get started for FY26. It's going to be critical that all of our advocacy groups work together to push for as much funding as possible for 988 in the next federal budget. We don't really know what's going to happen. And so we all want to make sure that we're prioritizing 988 funding and working towards that. As we get more information, as we get more news, we'll keep updating the jam. Right now, that's where we are at the moment. So appreciate the chance to share out, and I hope everyone's having a great start to their new year.
Joanne, I can't let you go just yet. There was a posting in the chat box to ask if you have any idea about when we can expect the confirmation hearings for RFK.
I think in the next couple of weeks, if I'm not mistaken. But I've heard a few different things, so I don't want to be quoted on that. But I've heard in the next couple of weeks, we'll hopefully have a date.
All righty. Well, Joanna, as always, thank you so much. Thanks for bringing us these updates, and we'll be looking forward to more as you get more information. So we are definitively thankful for you and for your service provision to us. We'll move now to our crisis talk, and we're going to invite in Stephanie Hepburn, who will introduce Lisa Sadie.
Thanks, Dr. Sims. Yeah, so I would like to welcome filmmaker Lisa Sadie. Lisa, can you share the impetus for your interest in filmmaking and advocating for family inclusion and mental health care?
Yes, I think I, along with so many other people, started because of my own child going into the rabbit hole of anorexia and finding out over years of seeking treatment and trying to follow what we thought would be best, just feeling like she wasn't getting better. And so it's just my journey into frustration and desire of a mother's heart to help their child.
And you talked about, at one point when you first started thinking about filmmaking, you wanted to create a resource for parents, not only to be able to have access to experts, but also to hear from parents like yourself. And I wanted to see if you could share a little bit about those resources. And also along the way, your advocacy for family inclusion. I think there's something that you said that I thought was very powerful, where you talked about how confidentiality is so important for the child. But sometimes that's used as a cloak and that excludes parents from being able to help the child and to learn skills to support the child. Can you talk a little bit about that?
Yeah, so first of all, I'll talk about the confidentiality and then about our films.
Mm.
So my daughter, I've talked to my daughter about, the years of therapy that she had and was it good to have confidentiality with the therapist? And she said, Mom, I needed to be able to vent and not worry that I'd be hurting you. It was really important for me to have someone to vent to. And I wish you did know the skills to help me when I went home. So I think two can exist at the same time, that we allow for periods of confidentiality. We allow for that child to be able to talk with the therapist, and we involve the parents in teaching them the skills that the child is learning to reinforce those skills at home, and that the family themselves can learn to expand the impact of the therapy. And when those two work together, I think it's much more powerful. So that's my belief around confidentiality and family inclusion. The films we have made, we have a website, mattersmedia.org. We have two parts of our organization. One's an MPO, and that's what I oversee. And we do films based on mental health needs. We've just finished our second film specifically for parents. This was the Parents to Parents After Your Child's Suicide Attempt. And then we had one before that for anorexia that just identifies both that you're not just both, you're not alone. What does evidence-based treatment look like? How can you become an informed consumer to help your child? How do you deal with a therapist that's not including you, and where is there hope? And we plan on doing many more films like this to help parents quickly become unified and understanding about what goes forward. We also do public feature film for the public, and we've done American Tragedy, which is a suicide prevention film, and we just added American Tragedy 25 added to it, in that we added the importance of securing guns. If you have guns in the home, you need to have them secured always, especially if you have a teenager in your home. Anyway, we just finished Blue Baby, which is about boys who were incarcerated at a very young age and how destructive that was to their whole future. And that one's being shown at the Sheen Center next month and is on Amazon. We have other films too.
Lisa, you shared that when your daughter was 21, she went to a center for anorexia treatment. It was a partial hospitalization, if I remember correctly. And they asked you a question that really changed your relationship with your daughter. Could you share what that question was?
Yeah, the question was, ask my daughter, what can your mother do to help you? Help her know how she can help you. And that was the first time we were put on the same team, with the expectation that we would communicate with each other what works, what doesn't work. And I thought that was such a powerful question that changed our relationship, and still to today is working. She helps me know what I can do to help her. I mean, she's doing really well, but she still has a complex brain, and she still sometimes needs my support. And she now knows to say, this is what I would like you to do to help me right now, Mom. It's been beautiful.
And both how to help her, what to say and what not to say.
Right, for sure, what not to say. She had anorexia, and I was never supposed to say, have you eaten enough?
Thank you so much for joining me. This is a great resource, and it was wonderful talking to you. And I'll pass it back to you.
Thank you all.
Well, thank you so much. Just looking at, and Lisa, while you're still on the line there, I was thinking about the public announcement films that you're talking about. Are they already out? Are they going to be distributed? Wasn't sure of the timeline there.
Right, they're all on Amazon Prime. Amazon. Some are on Amazon Prime. They're also on Google Play and Apple TV. Yeah.
Okay. Is there a way that we can get those titles? There've been a number of chat questions about setting up a link or finding those titles.
Yeah. American Tragedy 25 is the one about Sue Klebold and two other mothers, not Sue Klebold, the mother of a Columbine shooter, and two other mothers who are Sue Kleeball's friends whose sons died by suicide. That one is American Tragedy 25. American Tragedy was done before, and then but we hadn't talked about guns. And then we redid American Tragedy 25 for the 25th anniversary of Columbine. And that one's American Tragedy 25. It's on Amazon. Blue Baby is on Amazon. And Going Sane is on Amazon. Going Sane is kind of the presentation of what we talked about family inclusion.
Very good. Well, thank you. Thank you so much for that.
Thank you.
Thank you for the presentation. Thank you, Stephanie, for this. It's absolutely wonderful. I did want to go back, and Krista, if you're still on the line, if you could come off of mute for just a moment, Ms. Hauserman.
Yeah, I'm on here.
Thank you. Thank you so much. I had a personal question, and it's not personal, but when you were talking about the communications, you had mentioned in your talk about the police responders. And if they run across a mental health crisis, I wasn't quite sure in what you were saying, if they had the ability to call a separate line of 988 to talk to a mental health professional. And I'll reframe why I'm asking the question. What states have been sharing with us is there's been a lot of issues with first responders going to the scene of a mental health crisis, and instead of calling the 988 or calling a mental health professional, they call their own supervisor or whatever that gives them advice to use tactics that ordinarily would not be recommended if a mental health person was involved. So I was just, if you had a comment or something in that regard.
Absolutely. So I think that you're talking about an issue that can come up if law enforcement calls 988. It's hard. They're out there, and I don't think that they're going to get through to who they need to talk to quickly enough. And so and maybe they will in other states, I can't say that, but I think when law enforcement's out there, they need somebody that is a pretty highly trained somebody that maybe has a little bit more training in that type of a crisis situation than maybe your standard 988 staff. And I would say our 988 staff, they have hours and hours of training. Our vendor does a great job, the Vibrant training. So that's not it. I'm just talking about that sometimes like they need a little bit more like a supervisor. But anyway, that's where they can call the crisis hub. So we don't have a separate number for 988. But we're building those relationships. And so in our state, there are existing relationships, and we're building the relationships between the crisis provider and the law enforcement officer so that they can quickly partner. Maybe they're going out together, but that is where those partnerships are occurring. And again, that's the number when they're calling the crisis hub, they know that something needs to happen pretty quickly, that they're not calling that they're calling because there's a crisis and a response is needed, more than phone, text, or chat. So that's just a little bit different the way we're doing it.
Well, thank you so much for clarifying that, because again, what we're hearing over and over is that a lot of the police officers either don't know to call or don't call. So we're trying to say that if that service is available, they need to call, because it can be very helpful in getting things framed in a proper perspective about how to work with it. So again, Krista, thank you so much for everything in your presentation, and we're just so thankful to you.
Thank you.
Now let's move ahead, because we are coming up on the end of the session for today. And I just wanted to point out upcoming episodes. We have episode 206, which is the National Behavioral Health Crisis Care Guidance that Dr. McKeon spoke about a little bit during the SAMHSA updates, and that will be featuring Dr. Belina Shaw. And then following that, we're going to have our debate in 2 weeks. And this will be about crisis facilities should take both voluntary and involuntary referrals. Wonderful question to be raised in that. With Dr. Margie Balfour. We just want to make sure that folks see that these are people who don't necessarily take the position that they're taking, but for our sake, looking at it from both angles. So looking forward to the future debates and all of the things that are occurring for the Crisis Jam. You see the dates on it, and please don't miss out on any of those. So thank you all for coming to this Crisis Jam, and we look forward to seeing you on the next one. Bye now.